Good evening, everybody. I have 8 p.m. and I'd want to welcome you all to another edition of AO Trauma North America webinar. This evening's topic is non-union. Let's solve it. I'm Ray Wright from the University of Kentucky, and I'll be moderating the session this evening. Just a few housekeeping issues related to this evening's webinar. We have two faculty this evening, and I'll show you pictures later on, and we'll get to talk to them virtually over the Zoom. We have Mitchell Bernstein coming to us from McGill University Health Center in Montreal, and Paul Matuszewski, who's one of my partners from the University of Kentucky here in Lexington, Kentucky. Financial disclosures, all conflicts of interest or potential conflicts of interest have been resolved prior to this webinar. This is a case-based discussion of current state-of-the-art techniques in non-union management, and our faculty as well as I will discuss preoperative workup, infection control, bone defect management, and a variety of surgical techniques will be presented by the webinar faculty. Our agenda this evening are welcome and introductions right now, and then the remainder of this webinar, in order to keep it interesting, I think will be case presentations, and it'll include all the aspects that we just talked about: preoperative workup, management, decision-making, specific techniques, and options. Right around 9:05, we'll start to summarize and wrap up, and we plan to adjourn by 9:15 Eastern Time. We'll try to conclude with some questions and answers, but the faculty and I will do our very best to keep it interactive as best we can. I'd encourage you to use the Q&A portion of your Zoom for questions, and I will be moderating the Q&A and try to answer most of those questions and concerns live. Please also look for upcoming AO Trauma North America webinars. These are all held on Wednesdays at 8 p.m. Eastern Time. We have a variety of topics that are upcoming, and hope that you can join us for some of those. And thank you for your attention this evening. I'm going to move on now to introductory slides and introductory content for the webinar. So this evening, again, this is non-union and let's solve it. I'm Ray Wright from the University of Kentucky, and I have two not only colleagues, but a couple of people that I consider to be friends. I really enjoy seeing them in person when I can. One of the faculty members, Paul Matuszewski, I'm fortunate enough to work with, and so I think both of these surgeons are very bright, very engaging, and very good, and that's why I picked them to be with us this evening. Our learning objectives for this session involve aspects of classification of non-union, employing appropriate preoperative workups, identifying needs for aspects in your non-union treatment such as stability, biological augmentation, infection management, and bone void management as well, and then understand the methods to navigate these problems or potential problems in your non-unions. As a brief overview, non-unions are classified broadly as infected or sterile, and sterile non-unions can be classified by their radiographic appearance, either hypertrophic, oligotrophic, or atrophic non-unions. Hypertrophic with a large amount of callus and bony overgrowth at their area of the non-union, whereas oligotrophic don't have as much, and atrophic non-unions appear to have very little in terms of viability or overgrowth at the non-union site. We'll explore etiology and talk about this, but understand that the etiology of non-unions can be a combination of one of a few factors involved for your patient. Part of these can be patient factors, and these can be such aspects as medical comorbidities that your patients may have. We'll touch on the importance of identifying endocrinopathies, as well as vitamin deficiencies or other nutrition issues. There are other pharmacologic aspects that may be special to your patient that may make things particularly challenging, including nonsteroidal anti-inflammatory use, and we may talk a little bit about that, use of narcotics, tobacco, in general around compliance in our patient population. There are also injury factors to consider, and going back and understanding the original injury may be something that our faculty talk about, and understanding the original comminution, the status of the soft tissue envelope, whether or not there's bacterial contamination or infection, and bone loss. And then finally, surgeon factors. Was this prior surgeon you? Was this prior surgeon someone else? And how can you help to understand what the issues were related to a prior procedure if your patient has had a prior procedure? And these can be poor handling of the soft tissues, inadequate fixation or overfixation, as well as distraction. The reason classification is important is that it can broadly guide treatment, and we'll talk a little bit about that in our cases, whereas hypertrophic non-unions in general require stability, and atrophic and oligotrophic cases may be plus or minus stability, but certainly biologic stimulation may be a very important treatment portion for your non-union. And then when we talk about infected non-unions, I think our faculty will speak to the fact that infection control, as well as stability or plus or minus stimulation biologically, may be very important aspects. Key aspects of the decision making that our faculty will talk about are the location of the non-union, whether or not it's infected, the status of the soft tissue envelope, the presence or absence of deformity, whether or not there's prior fixation, and the overall viability of the bone. They'll talk to you too in what I think is a very thoughtful, thorough, yet succinct 3-point checklist for workup for non-unions. And those involve investigating and optimizing the host or your patient, both locally and systemically, ruling out and managing infection if it's present, and then achieving stability and correct alignment. And it's usually surgery is required for that. And so to summarize, and why I think this is such an interesting and very important topic, is this is really the topic where all the principles, the AO principles of fixation, are brought to bear when it comes to effective soft tissue management, maintaining alignment, proper stability, and getting your patient moving and mobile. And so to summarize at the end, we hope that we allow you to more effectively classify your non-unions, talk about appropriate preoperative workup for these non-unions, identify needs for stability, biologic augmentation, infection control, and bone void management, and then understand the methods to obtain. And so again, we're going to do this in discussion format. And so first up this evening is my partner, Dr. Mataszewski, who is coming to us from actually just down the road from where I am here in Lexington, Kentucky. And so, Paul, if you would please show us the first case you have for the audience.
Yeah, thanks, Ray. Let's go ahead and get the screen going. So thanks everybody for joining us today. I have no relevant conflicts of interest or disclosures for this particular event. But the main thing that we really want you to take home today and going through these cases is not really just a textbook discussion of all the factors and different ways to treat a non-union. We can treat non-unions in a lot of different ways. There's lots of correct ways to treat things, and there's also wrong ways to treat things. But I think that the main thing is sticking to the principles in treating patients and moving forward with a very systematic approach, so that you can be successful in treating these non-unions, because you don't need to be something special to treat these. You just need to follow the principles. And as long as you do, you can be successful. And it doesn't mean that you have to do it the same way we do, as long as you follow those principles. But one of the things that I think is really important when you first go about addressing these problems is it's not just about the bone healing. It's about treating the patient themselves and what their goals are and what they're looking to do, what the individual aspects are of these patients. Because some patients, their main complaint isn't that their bone isn't healed. It could be something else, and you have to be really careful and really listen to your patients and really take a thorough history. But in general, with approaching these non-unions, we really like to look at this as sort of a three-step approach. And the first step of which is to look at the information that you have, listen to the story, the examination, and try to find out, why didn't this fracture heal in the first place? Because that's what's going to give you the clues into understanding what to do next. And I like to look at these in different ways, like extrinsic factors and intrinsic factors. And Dr. Wright alluded to this in talking about patient-related factors like smoking and metabolic causes for non-union, intrinsic fracture characteristics like mechanical stability. Was there poor fixation at the beginning? Was the improper implant selected? Was there an alignment issue that was causing an undue mechanical stress at the fracture, which is causing this healing problem? Or was there something to do with the biology of the fracture? Is it infected? Is there poor bone health in there? Is there poor bone contact? Is there too much combination? Or there's bone loss and so on and so forth? And these are the things you need to really, when you see these patients, look and say, okay, why didn't this heal? And then you can jump into the next step. And then how can I treat this based on these possible causes? So once you identify each individual cause as best you can, because it's not always possible, then you can begin to step-by-step come up with a treatment plan to address each individual concern. And that could be with either treating the biology by adding autograft or controlling infection, optimizing the implants in the event of a problem associated with stability or poor fixation. You can address that. Compression, maybe not. And then also things like alignment. And those are the things you want to go through systematically, step by step, to make sure that you hit each one of these causes so that you can determine the best course of treatment. And then the third step really is very amorphous, but it really comes to how can I individualize this treatment? Because not every patient is the same. And you'll see, we'll talk about cases that involve internal implants and external implants. And some patients can tolerate some and some cannot. And you know the patients that we're talking about. And the other thing is that sometimes patients, they be able to tolerate the treatment, but they might not be able to adhere to the treatment plan. And these are the things that you really need to address with your patients, and then manage the expectations. Treating non-unions is not a straightforward process. And sometimes, even though we'd like to think we're perfect, it's not 100% successful. And you really need to discuss with your patients, you know, what the chances are and what's involved, because sometimes it's not a straightforward process. So keep that in mind while we're talking about these cases, and we'll try to reference that back as we move forward. And with that, I'll present the first case. So the first case is a 27-year-old male who is involved in a motor vehicle collision. He's a state trooper, so he's a police officer here in the United States, and he was a polytrauma. So he had all four extremities injured, and his pelvis as well as clavicle were injured. The injury of interest is an open tibial shaft fracture, which also had a ipsilateral plateau fracture. All of his other injuries healed. And 10 months from his injury, he still had pain and failure to progress with his non-union. He's a healthy guy. He's an active guy. He describes himself as taking down the bad guys, and he's a non-smoker, and he wants to go back to active duty as soon as possible. He's ready to go and hit the squad car and chase after all of the criminals. So here's his x-rays. And you can see these are two views of his tibia, which have a relatively atrophic appearance. And you can tell looking at this that there was quite a bit of injury to sustain to the tibia. You know, this was an open fracture. There's a butterfly fragment, and there's multiple segmental fractures as well as the plateau. So this was quite a bit of energy that was absorbed to this extremity. On examination, he walks with an antalgic gait. He has some edema about the mid-tibia. You can see that on his x-rays from his AFO. He had a foot drop from a perineal injury at the time of the injury. And you can see where the AFO is strapped on because of the edema that he has. He stands in neutral alignment, and he has no obvious limb length inequalities and doesn't complain of this to me. And he has no draining sinuses or signs or symptoms of infection. So we start working him up, and on further workup, we start going down the road of determining, you know, what's the first thing that we think of with an open fracture, and that's infection is always a concern. We obtained an ESR, CRP, and a white cell count, all of which were negative. And his labs, his endocrine labs were otherwise within normal limits, and his imaging you saw. I felt like in this case, there was a CT scan didn't add anything, so we didn't have a CT scan. So to go back to that checklist that we were talking about, first step, why didn't this heal? And, you know, we look at the intrinsic factors. Was there an extrinsic factor for the non-union? Was he a smoker, metabolic issue? I didn't identify anything. And the truth is that he also healed every single one of his other fractures, regardless of all this. So clearly he's a healer and he can heal these injuries. So this was something specific about this extremity. What about a mechanical factor? Well, you know, his fixation was adequate at the time of surgery. We wouldn't have treated this any differently with an intramedullary nail. But you can see when you look at the x-rays, and we'll show them again, that now because of that butterfly segment and how it's positioned, there is a little bit of instability there as a result of a mismatch of the implant. What about biology? Well, I think that biology in this case is probably the biggest thing. And, this was a high energy, atrophic, non-union, and with not much healing going on, lots of soft tissue stripping. There's a large open wound, and of course, a high concern for infection. So this is something that we're going to have to add something to build on his biology. And I think that's where we look at things. So how can we optimize it? Well, in terms of the biology, in terms of his atrophic experience, we're going to have to do something to stimulate this, either via adding autograft or doing some type of reaming or something additional to just fixation. Okay. What about the implant? Yeah.
I'm sorry to interrupt, but can I ask you a question that one of the attendees has asked? Is just to clarify, was that medullary nail placed at an index procedure, or is this a post-op? I think this is what the panelist is getting at. Is this index procedure that we're looking at here, your first X-ray?
No, that was 10 months after surgery.
Okay.
And the nail was placed at the index procedure. It's pretty standard for us if we can primarily close open wounds. The evidence is pretty strongly in favor of primarily closing open fractures, and it's actually associated with a decreased risk of infection. So that's pretty standard of care for us here.
Yes. And how open was the injury? Could you give us an idea of the Gastillo classification?
Well, this will be a 3A, and the size of the defect was approximately a 12-14 centimeter opening with a good amount of soft tissue damage to the superficial posterior structures.
All right. Thank you very much.
Yeah. So back to the implant. This is a case where we mentioned that the intramedullary stability is somewhat lacking as a result of the way that this fracture tried to heal. So increasing stability will help this. So Dr. Wright touched on this with hypertrophic non-unions and looking at, we know that very typically when you think of hypertrophic non-unions, you think increased stability. Well, non-unions in general love stability. And so you can never really go wrong with non-union treatment in most cases with adding stability. And you'll see that as a common theme. What about a limb alignment? Not really in this particular case. And I think this is something, Mitch is going to talk about in some of his cases, but I think this is something that we tend to sometimes ignore. And it's very important to see the whole patient because this plays a significant role in how you address these problems. So how can I individualize this treatment? Well, whatever we decide to do is going to have to be something that is going to be single stage to get this guy going as soon as possible. Now, sometimes there's not that many options available to you. And sometimes you really need to, you have to temper the patient and set their expectations. I've had plenty of patients that come back to me and say, well, I can't tolerate anymore. Well, this is what it's going to take. And you have to have that discussion. But in this case, obviously a single stage treatment would be preferred. So I'm going to open up the polling here, but the first question that I wanted to open up to the audience was, what do you guys think? What would you do now that we've sort of discussed this case and you can see this guy's x-rays? Would you do a dynamization of the nail or posterior lateral bone grafting, resection, plating over a nail, exchange nailing, hardware removal, limb lengthening nail? Let's see what the group is looking for. And I'm gonna ask Mitch what he thinks he would do and what he thinks of what the audience would do.
Well, while we're giving the audience a little time to answer, panelist question has come up, and I think this is a very good question to ask since we've got a couple experts on the line. How can you would you clarify the definition of a non-union? Mitch or Paul, whenever you have a bone that's slow to heal or just not healing, when do you use that verbiage and when do you start to employ action? Does it depend on the bone? Does it depend on the patient? What do you think?
I think it really depends on there's a lot of different definitions for non-union versus delayed union. There's the FDA definition, there's failure to progress over a series of 3 x-rays. But then, you also have just failure to progress at time. And, this guy has no progression over 10 months, maybe a little bit of healing, but not all that much. So I don't really look at it as this is a non-union versus a delayed union. I look at it as when am I going to seek action. And for me, that's a lack of change over time. And, you look at, specifically with tibia fractures, Bob O'Toole and the shock trauma group looked at this and trying to come up with the NERD score, trying to figure out, what would likely progress to non-union, because that really is the panacea. Wouldn't it be great if in the operating room we could say this one's going to heal and this one isn't going to heal? And there are certain things that do contribute to that, but a lot of times I think we just don't know. I don't know what you think, Mitch.
I think it depends on, like you said, the bone, and clinically what you're looking at. And, if it's a nail that's quite durable, I may wait longer. If it's a plate and I want to avoid catastrophic failure where it's going to be an issue, I might be more aggressive. So it really depends on what the failure will look like and in terms of how early I'd intervene.
When do you stop using the words delayed union and start using the word non-union?
It's an art, it's an art. it's very, listen, I think, like Paul said, it's there's all these definitions, but practically speaking, months, you're talking about months, but if you don't see bridging, like you said, Bob O'Toole has some really good scoring systems. If you don't see bridging callus on at least 2 cortices after 4 months, I think you should start to get a little bit anxious. And we're talking about tibia fractures.
Yeah, I think that's an interesting point. Out of the Carolinas group, they published a study on this, looking at tibia fractures specifically, and any bony bridging in 3 months was predictive of healing. And that's a lot of times what I use to sort of guide my treatment. But when do you think that you're pulling, let's say for a tibial shaft fracture like this, Mitch, when do you think that you are pulling the trigger on when?
Long time. This one, a long time. I would wait a long time for the soft tissues to heal, his other injuries to heal. Like you said, you're tailoring this. So this is a polytrauma patient, get him everything healed, get a soft tissue to heal, and then just work on a isolated tibial non-union. And he's got an IM nail in there, so you can wait a reasonable amount of time. If he's pushing you, he's like, dude, I can't wait. I can't wait the formal 12, 16 months for you. I got to get on my way. I think it's reasonable after 7, 8 months to maybe pull the trigger, but like tibias take a long time. So if he's doing okay and you have good follow-up and it's not too bad, I would let him go. Right to your polling question, I know you didn't ask me, but I'm going to tell you, I would not do nail dynamization. That makes me a little bit anxious for tibias in terms of its predictability, and I don't understand it. I didn't mean to be too aggressive with the critique, but I don't do it for tibia.
Yeah, no, I'm not in general, I'm not really a fan of nail dynamization. I think when you have a nice femur fracture that's perfectly transverse, I think it can work in your favor. But I think that for the most part, nail dynamization seemed like it was a good idea to add gradual weight bearing compression, but the studies really haven't lent itself to answer that. And in a case like this, you're not going to have a good amount of stability there at that non-union site. It's not going to be a perfectly symmetrical site. So I'm not sure that would do much. And the big answer choices that people jumped into are plating over the nail and posterior lateral bone grafting and exchange nailing. And I would say that each one of those is very viable and pretty common procedure that can yield pretty good results. I mean, the results of posterior lateral bone grafting are 90-95% with BMP added, and there's a series on that. And there's quite a few series actually, and plating over a nail can work pretty well. What would you do for this case, Mitch?
I'm not going to answer you. I'm going to just make a comment. But no, seriously speaking, and we're all on here on this webinar, 22% of us want to do nail dynamization to destabilize things. And then there's a fair amount of, 22%, exact same number of people who actually want to increase the stability with bone grafting. And I think that's the art of these non-unions. And what, I'm not trying to be cheesy, what really makes it a challenge is I love this idea of plating and changing the strain in there, which I have no idea what I'm talking about, but that's cool. But then 22% of the time, people are dynamizing the nail.
Well, I was going to ask you a question before we got into your answers there, Paulie. A couple of the attendees um, were asking, what about dynamization? Is there an indication to dynamize anymore? Do we just not do that anymore? And if you do, is there a timing that's optimal to dynamize?
For me, it's extremely rare that I would dynamize. I think the only cases that I would be through the femur, but that's not really. That tends to increase instability, and I don't particularly like that for non-unions in my experience. I don't know what your take on that is, Mitch. You kind of touched on that.
I was answering a question on. I'm answering one of these very good questions about closing tibias. I'm going to defer.
Okay. Well, let's get in discussion about what do you think of these answers, Paul, and then show us what you did.
Yeah. So we kind of touched on that, but I think the ones that are the big hits, minus the nail dynamization, would be all viable options. And I think that's because you're addressing those problems, and we'll get to that in just a second. So, in terms of our problems, when we look at this was an atrophic non-union. So there's a lack of stability. And I chose to do exchange nailing for this particular case. And what exchange nailing accomplishes to address this particular problem is a combination of two things. One, reaming actually stimulates an intramedullary blood flow. So that will increase your activity and your biological activity. And the other thing is that reaming also deposit local bone graft in the area, in some of those areas where there's a little bit of a void. So I think that it addresses two problems, and I think that's a good answer for that. As far as stability, because I mentioned that I noted stability was an issue. If you do exchange nailing appropriately, it's been written up that essentially you want to do at least 2 sizes greater. Never understood exactly what 2 sizes greater. They usually come in 1 millimeter increments, but what about when they come in 1.5 and the next is 1? But generally speaking, for me, it's at least 2 millimeters, and it needs to be adequately addressing the intramedullary fit of the canal. So you could put the largest nail possible in there, and if it does not address the stability and it doesn't have a good isthmic fit in the bone, meaning that you are not increasing the intramedullary purchase or the endosteal purchase on that nail, you're not increasing the stability. You have the sort of quote unquote hot dog in a hallway phenomenon. So the nailing, the larger diameter nail will increase stability, and that's one of the things that it will accomplish. So what about patient goals and concerns? Well, they want to get back, they want to keep weight bearing, they want to get back to work and still, even while they're in the course of their treatment. So they want to go with what they can weight bear on right away. And this allows us to do it. And a lot of the options that were selected, including the posterior lateral bone grafting and plating over the nail, a lot of folks will treat those with weight bearing as tolerated. But I think it's important that we manage the expectations with exchange nailing, because when I first started my practice, I thought that exchange nailing was the panacea for a lot of non-unions, but it really isn't. The success rate, in Brinker's series, he talks about 90-95% success rate with certain criteria for diaphyseal non-unions with a 50 to 100% cortical contact and so on and so forth. And the results are quite good. But then you look at Mike Bossi's series on exchange nailing, and it's something like 56% success rate. So there's a huge difference. And when you see a huge difference between the two, it makes you think it's probably somewhere in the middle. And, there's probably a lot of factors that may be surgeon driven and sort of an unconscious bias that, Brinker has in his series versus a lack of bias maybe in the other series that have a lower success rate, that these folks are tailoring the exchange nailing treatment to when they think it's going to work and work well. And we have a local series here that we did with Inova Fairfax that's going to be published soon and presented at the OTA, where we looked at exchange nailing in femurs and tibias. And what we found was a little bit better success rate of 60 some odd percent. But when you have a situation where you have the need for bone grafting, or you think you want to add bone graft, which is not how it's been originally described, but still people expand the indications. It increases your failure rate 4 times than that of all comers. So it's something to keep in mind. And I think it's important that you do that. And the other thing is that exchange nailing takes a long time to work. In our series, we had at 6 months, only 60% of folks had healed by 6 months. So even at 3 months, it was something like 35, 40%. So it takes a long time. It's not like you're going to see it 6 weeks when you do treatments for non-union and you do an exchange nailing procedure. You're not going to turn around when you get your post-operative x-rays at 6 weeks and say, oh, it's healed and now you can do everything you want to do. I think that's really important that you discuss that with your patients ahead of time, so that way they're not surprised when those follow-up x-rays come in. So here's my gentleman's x-ray at 6 weeks. And you can see just that. You can see a change in the, the nail is obviously an increased diameter, and you can see on that medial cortex, you see bridging bone, and you see, the lucency has disappeared on that lateral cortex and posteriorly and anteriorly. So it's really starting to fill in. And I would say this is healed at 3 months with greater than 3/4 Cs, fully bony bridging. And he actually went back to work in about 6 weeks. His pain went away by 6 weeks, and he said that he was ready to go back to work. And he's a state trooper, and he's tackling folks that are dealing drugs and the bad guys, he says. So he's really at it and going to it. So this was a successful treatment for him.
That's a great case, Paul. One of the questions that's been brought up in terms of nail exchange is, when you do this, are you exchanging through an infra or suprapatellar portal?
I think that's a great question. And what I look at it is with revisions. Anytime I'm doing any kind of revision of the tibia, this nail was put in a suprapatellar approach. Anytime I'm doing a revision, I will use an infrapatellar to extract the nail. And if I'm worried about the alignment or I'm doing something different for the patient, I will do a suprapatellar approach. But if it's just going to be an in and out swap, I'll do it through the infrapatellar approach. It certainly is, a little bit more difficult with the imaging, and we've shown that at our center with we published series on that for tibial shaft fractures, not necessarily non-unions, but I think it's certainly, you can do it either way, but that's my general approach.
All right, thank you. Now, when you exchange, is there any role for opening that fracture site or curetting or drilling those fracture edges? What do you think?
I think that actually goes against the principles of what exchange nailing is all about. And exchange nailing is all about those two things that we were talking about, was the increasing the stability and then increasing the local activity and the deposition of bone graft. So a lot of these fractures, there's a frequent phrase that people will say to quote unquote take down the non-union. Well, there's been plenty of studies to show that in between those fractured ends where it's non-united, there's a great deal of progenitor cells that are pluripotent, that are just ready to turn into bone. And taking down the non-union can be deleterious, and it decreases the blood flow. I think, when we go back to those original points about why did this not heal? Well, probably the reason why this didn't heal was because those bone ends were pulled out and stripped. So they were stripped of their extramedullary blood supply, and they were stripped of their intramedullary blood supply. They weren't disconnected, so we didn't debride them and take them out. So we let them reestablish their endosteal blood supply as well as the extramedullary blood supply. And at this point now, the bone is poised and ready to heal. And I think that exchange nailing takes advantage of that. And by doing that sort of thing, it decreases your success rate. And that's exactly what we found in our series here.
Okay, Paul, thanks. I think it was a great case, and I'm going to turn it over to Mitch for the next case, and we'll see what he's got north of the border.
We have a lot of non-unions here. I use the term, Paul, osteogenic tissue. I agree with you with this concept of taking down non-unions. Okay, so your case was very good, Paul. I have a case as well. So there's a 34-year-old who was on a motorcycle, was hit by a car, and he sustained a open tibia fracture. These are his injury x-rays. And I ask you to reflect on how you would describe this fracture, whether you're going to use an AO classification, talking about the comminution, the fact that it's opened, and what intraoperative debridement strategies you use. Maybe I'll just ask Paul quickly, what do you do with these big bone defects in diaphyseal open tibias?
Yeah, for these, if they are exposed to the air and there's really no soft tissue attachments, those go in the bucket. And sometimes it hurts your soul to do that, but there's definitely been plenty of times where I have taken care of folks where people tried to save these pieces and done creative things like mini frag plates and lag screws outside of the intramedullary canal and nailed it, and wound up going later and taking those out for a nice resection and transport case. So I tend to take those out, and I think, be aggressive and appropriate in your debridement is the name of the game.
And just reflect again on fixation constructs. I think most people would probably put a intramedullary nail for this injury. So here's the immediate post-op X-rays, and again, I'd ask you to look at the plain films, immediate post-op plain films, as well as the intraoperative X-rays, and look at this bone defect. And again, how do you define a critical size bone defect? I think is important. I think it maybe complements what Paul was discussing with how you would potentially treat this. And again, how would you potentially set this up from your index surgery? So I think looking ahead at potentially the non-union surgery, you can mitigate some of that looking here, where you may define this as a critical defect and set it up for a secondary intervention. I just wanted to talk about this study. This is a good friend of mine, Will Lack, who's a very, very smart person who looked at open tibia fractures with bone defects between 10 and 50 millimeters. And he called it this RAPG, radiographic apparent bone gap, which was the average of the bone gaps on the AP X-ray, medial lateral cortices, as well as the anterior posterior cortices. And basically, patients who had an RABG on average less than 25 had a reasonable chance of achieving union without any intervention, whereas patients who had a larger bone defect did not. And I'd ask you maybe just take a look at that study. It's a pretty good study to help give you, again, the science for some of the art of some of these lesions that are not so straightforward. So he was, trucking along here for a good year when then he was referred on to me with pain at the non-union site. It was a type 3B, so he had a flap, rotational flap and a skin graft that healed quite well. He had no history of any infection at the time. So, the question is, how do you approach this? So I really like what Ray said. Oh, Ray's coming on. Ray, do you have to interrupt me? No? Okay. I really like what Ray said at the beginning, and I really, really like what Paul said as well. So this is a bit of a repeat on purpose because, again, we got to look at the location, and Ray mentioned that. So, is this a periarticular lesion where stability is going to be an issue? Is this a diaphyseal injury that a lot of us are very comfortable doing exchange nails? Is this acute? Is this chronic? Is there a flap present? I never say it's not infected, but I say, is it, rule out infection versus infected. And then this concept of bone loss. What's the bone defect size? Is there any existing limb length discrepancy to calculate the total bone loss? And like Paul mentioned, the host and host factors. I'm not going to go into this in detail, but I do put this in because I think Paul is absolutely, absolutely, absolutely correct. There is a rhythm of non-union surgery. It's comprehensive, it's slow, it's aggravating, it's phenomenal, but you really got to look at why didn't this fracture heal? And then again, determine how best to treat on the causes for non-union. How do you optimize the situation for the patient? And then again, how do you individualize the treatment? Which I agree, it's not cheeky, it's true. So this is a patient who was very OCD, I was very anxious. He had an implant in there. I was very concerned about infection. His labs were slightly elevated, a little bit low on vitamin D. Like, you know, what do you do with these things? Do you even get labs anymore, Ray or Paul? People are talking about, you know, I get them. I don't even look at them sometimes.
I still get labs, and I tend to look at them every time. And we have a set non-union and infection panel, and usually I'm looking for metabolic conditions in addition to the presence or absence of infection, because I think both of those play into my decision making when it comes to non-union. So I still get them, I still look at them. My boss and good friend would say you'll never be sad if you order labs as long as you're looking at them. And so I still tend to get them.
Yeah, I tend to get them as well. And I think that, you know, specifically for something where you're concerned about infection, you know, there's some debate in the literature about the utility of ESR CRP and white cell count. I mean, there was just an article published in JOT back in March looking at this and saying that basically it's poor positive predictability. And they did that via, and this is a Brinker article actually, that did that via a Bayesian analysis. And basically what that means in fancy statistical talk is about pre-test probability. So when you are thinking there's a problem with infection and you get those labs, they help confirm your suspicion. They're not necessarily good to identify things that you don't think are infected and whether or not they are infected and surprises. And certainly maybe their negative predictive value is not super great, but I think they can be helpful. And I think what it comes down to is really what your clinical suspicion is and how you approach the patient and looking for those subtle cues and the exam and the x-rays.
So here's the CT scan. So he's got about 20 millimeters there. You know, he definitely doesn't have bone contact. He's got some Gapparoonies here. I do what Paul said. I also look at the overall alignment as well as limb length. So this patient was pretty, he was well aligned. So there's no existing coronal, sagittal, torsional malalignment, and limb lengths were good. So that was good. So again, I usually generate a problem list. So 34, young guy, 12 months out. It's a 3B tibia. He's got, I think it's a rule out infected tibial non-union. I don't think it's frankly infected. He has bone loss, approximately 20 millimeters, not like, 70 or 80. He's got a retained IM nail. He has a healed fibula. What's your plan here? So let me go to plan options. How about that? Plan options. Boom, 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 boom. It's not a polling question, so I'm going to have to ask Ray or Paul to comment on some of these things. What are you thinking here?
How about,
and then Paul, this extends a little bit from yours, right? Because yours was, I think, potentially more amenable to an exchange nailing. If we did do a polling, and I'm sorry I didn't, maybe people would think they're happy that, you know, you have to do a bone grafting here. I don't know what you think about that.
Yeah, one thing that I would bring up that I was thinking about when you were presenting this case and talking about the RABG, what was the RABG on this particular case that you calculated?
Yeah, I didn't calculate it.
Was it over? Would you say it's over 25?
Yeah.
So in a case like that, do you think there's a role for index treatment with Mascalay planned stage procedure?
I do. Yeah, I do.
I think it's really, you know, sometimes it's very obvious and then sometimes it's not. And I think that in this particular case at the get-go, I don't know if it would have been obvious to me to plan for that, because I think, you know, you can certainly see that healing medially and then posteriorly, and then that lateral side just maybe never healing, but the patient be asymptomatic. So you never know. As far as options are concerned, looking at these, there's a lot of boom, boom, booms in the room here. And let's see, so elevate the flap with plastics, excise and debride the segment for bone transport. So essentially excision with either Mascalay or some type of transport versus a combined procedure. Well, no, the last procedure would be to do some type of compression with a bone grafting and a frame. I think that honestly, all of those things are very, very viable. Maybe not to elevate the flap with plastics. I'm not sure what that's going to accomplish, but I think that going back to our original comment, that some people at the get-go would have just trimmed this fracture at the get-go and left a defect with a transverse defect and said, we're going to go transport out the bat. Steve Quinnen from Miami, that's what they do. I spent time with those guys down in Florida, and they do like 100+ frames a year with that exact indication. So, there's certainly a role for that. And I think that's a good opportunity for improvement here. I see exchange nailing with bone grafting. I think that in my hands, that would not be a great option for this case. I think that, our series here demonstrated that if you think that you need to add bone graft to get that to heal, then exchange nailing is not the answer. It's going to increase your risk of failure tremendously. And we learned that from our series. The rest of them all use creative techniques to deal with that bone defect. And I think that they are all very viable. What about, is one of those options posterior lateral bone grafting or posterior bone grafting? Or is that first question?
I didn't put it, I don't really have any experience with that, so I didn't really put that in there.
Yeah, I think that would be an option too. I worry about with that soft tissue there, whether or not that would support healing from the undersurface and developing that synostosis with the fibula. So that wouldn't be on my top list of contenders there.
A lot of interesting options. Mitch, show us what you did.
I chose number 7. So this guy was very anxious, and like you said, Paul, he tailored to the patient. He did not want a surface implant, or he did not want a new implant, an IM nail. So I basically he was actually asking for a ring fixator, which is usually a good sign for a frame. So we took out the nail. I took the opportunity to re-ream. I know there's a question about curetting the non-union site, but I re-reamed to re-stimulate, recanalize the canal. And then I added iliac crest at the index procedure to augment the bone graft. I took cultures, it was not infected. And when I went in there, it was not infected and the bone was viable. So we put on a hexapod frame and just compressed this thing over 7 months. And he went on to generate some nice bone and did quite well with no retained implants at the end. So my take-home messages for this was be able to define the critical size bone defects, like we were talking about. I think stability is a prerequisite for bone formation. And I think, hexapods are really good for prolonged stability. You can get sustained compression, you avoid implants. So if it is infected, you don't necessarily have to worry about contaminated metal.
So one of the questions from the audience, Mitch, was about dynamization with osteotomy of the fibula, which I think essentially you did sans dynamization with the X-Fix. And I think that I would agree that if I was going to osteotomize the fibula and allow that to compress, I would want to do it actively. Maybe you could comment on your algorithm for compression. How long does it take? How long do you do it for? How gradually do you do it? What's your algorithm?
Well, with a hexapod, I usually just keep doing it weeks and weeks and weeks until the struts are just not able to be turned. And you're talking about 6-7 millimeters typically, but in the OR maybe 2 or 3, and then the patient every week another 2, just to maintain the alignment and compress. If there's no loadable fractures, obviously I'm not going to do that. But I was trying to load at least this segment and the other segment here.
Mitch, I think all your options for treatment were interesting ones, and I think it's an elegant result that you have. And so one of the questions that comes to my mind is, what's the difference between this and Paul's case, and why can't we just exchange nail something like this, or can we?
I think you could 100%, and I wanted to. He he really was, like I said, he really did not want a new IM nail in the canal.
That is
It
so
is really what it,
yeah.
yeah, it was really what it came down to. And to be honest, my preference would have been that. I think this is a bit more, I don't know if the word's bulky, but I think it's very elegant. Like you said, it's very safe. It's percutaneous. It's amazingly strong, and you can get sustained compression. So, you know, it worked, but it's a bit bulky.
Let me ask both of you guys, because this seems to be coming up. What if you're planning for exchange nail, but you're highly suspicious of infection?
Yeah, you see
for antibiotic nail and then exchange to something else, or how does that go for you all, and how do you make that decision?
That's okay. So great question. That's totally different. Okay, I did not emotionally have that going into this case based on his soft tissues, based on his perioperative, postoperative course, and lack of any draining sinus, any infection, low probability of infection in there. And I did look at the bone before I proceeded. I'm thankful, you know, facile with the frame. So if I had any concern about infection, what I would do is abort the index bone grafting, put a piece of cement, and then, you know, I got my stability with the frame. He gets a PICC line antibiotics, and then you sort of abort and set him up for a 2-stage treatment.
Okay. Paulie, anything different? You know, if you have like a high sed rate or CRP, or you've got soft tissues, your consideration, do you do 2-stage exchange nailing with antibiotic coated something, and then exchange to real medullary nail, or how do you do it?
I think for something like this, if I was concerned for infection, this is something that's likely going to get an antibiotic coated nail, and plus or minus some type of spacer for local bone graft delivery later. With the idea in mind that, you know, perhaps just exchanging the nail with the antibiotic coated nail by itself may do something, because usually we're upsizing to 12.5 millimeters with the overall coating of the nail. With the idea that probably I'm going to go back in time and deal something with that defect. Let me ask you something, Mitch. If you were going to not treat this with the frame and you went back with the exchange nailing, would you bone graft at that time? Mitch is on mute.
I have some technical difficulties here. You can hear me okay, right?
Yeah.
Say the question again, Paul.
If your preferred treatment for this one was exchange nailing.
Yes.
So if you did exchange nail, what would you have done? Would you have bone grafted? Would you just exchange nailed it? What would you have done? Would you have taken cultures of the reamings? What would be your algorithm for that?
In this case, I would have taken cultures from the non-union site. I would have done an approach. I agree with you. I wouldn't necessarily have elevated the flap. I'd probably just elevate the leading edge of the flap in this case and get to the bone to get to know what the bone looks like, take cultures. And I think the bone defect was too big for me to just close the wound, upsize to and re-ream. So I would have probably added the iliac crest. The other little caveat, and I'm sorry I'm talking so much, is if I really want the debridement part of it, you know, if you want to exchange nail and keep those reamings as part of the bone graft, close your wound is what I was taught. If you want the debridement reamings, leave your wound open, which is what I did. You re-ream, everything comes out, you irrigate, and now your reamings don't serve as bone graft, they were a debridement, and then I dumped the iliac crest in.
I think that's an interesting point. I teach my residents that a lot when we're dealing with open fractures, to close, a lot of times with tibias and such, to close the wound and take advantage of that bone graft that's deposited locally. And if you want to use the open wound as an adjunct for your reduction, do that later. You can always open it up while you're working on it, because I think that's beneficial for these in that exact context. So I guess we'll move on to the next one, Ray.
Please, yeah, this is great discussion, and I don't mean to interrupt it, but do want to be respectful of everyone's time, and so let's get these last two cases going.
All right. So the next case is a pleasant female who's a teacher. She's obese but otherwise healthy. She's a non-smoker. She has a history of a closed femoral shaft fracture And guess what? She was treated with exchange nailing once already, and she's 8 months post-op, and she's still painful with every step. She doesn't have pain at rest, only when she's walking. She wants to get back to work. She's currently unable to teach. This happened when she was at work, so this is a working compensation case. Here are x-rays. You can see a relatively oligotrophic non-union in the metadiaphyseal region of the femur. On examination, she's walking with an antalgic gait. She walks with assistance. She has neutral alignment. She has no apparent limb length discrepancy or malrotation. And she's healthy appearing. She's normal cephalic. There's no cues on her exam for something like Cushing's or hirsutism, which would be associated with polycystic ovarian syndrome. She does have a BMI of 40. She has no draining sinuses or signs and symptoms of infection. On further workup for her, all of her inflammatory labs were negative. Most of her labs were negative, except she did have an elevated TSH and a decreased free T4 with vitamin D insufficiency, and no CT scan was obtained. So, I want to open this poll to the audience and start a discussion to ask, this particular patient had decreased vitamin D, which we all know is very common in the population, and some other findings. So what's the role of an endocrinologist or evaluation further? And I'm curious to see what the audience thinks with the next polling question. What labs do they draw? And this was a question that was asked earlier, and we sort of touched on it. Are you just drawing infection labs? Are you doing a non-union panel like Dr. Wright does? Are you doing something else, or just treating everyone, and so on and so forth? So I'm curious to see what other people say. Mitch, maybe you can comment on what you do.
I still do CRP, ESR, white count. I don't do vitamin D anymore. I just treat everyone with a 10,000 unit per week and a 500, 400 BID for 12 weeks. So I don't really get, I think also the 125 hydroxy lab test is at our hospital is like a send out. And I think it's expensive, so I don't know. I don't do it anymore.
That sounds Canadian to me. I don't know.
When I was in Chicago, we looked at it, and I think it was like 70% or so of our patients were low anyway, so we stopped doing it.
So we have a quarter of the people really are interested in looking for infection and sort of share the same view that you do. And then we also see folks checking vitamin D as well. And then a good chunk of people, 34%, actually check other labs, so endocrine-based labs like I did in this particular case, to see what they find. So that brings the next question is, what about referral to an endocrinologist? And for these patients, what are you doing, and what are folks doing? Should all patients with non-unions be referred to an endocrinologist? Should patients who just look kind of funny be sent to an endocrinologist, or maybe there's some type of screening that we're doing? What do you think about that?
When you say look funny, Paul, do you mean some sort of osseous X-ray finding or some sort of laboratory finding?
Both. Well, no, actually, no. Some type of X-ray finding or story that doesn't make sense, or some type of physical examination finding.
I got you.
Every once in a while, those zebras, they gallop into our office, and they do happen. And there might be something that brings you back to those step 1 days for those of us in the United States, and thinking about all those different things that people could have. And it looks like, we have a good mix of, 30% of folks think, if they have a pre-existing condition, probably like hypothyroidism, or if they have hypogonadism, or based on screening labs, or if they don't have a good reason to heal. And I think that's pretty common for people to be split on this. In my particular case, based on the article, actually, I keep bringing up Brinker's name that he published, looking where they sent everybody to endocrinologists, and they did a battery of tests, and they found a certain number of common things that were quite common, including vitamin D, to Mitch's point, that they started testing everybody and everybody was positive. And, so I'll treat that on my own, but anything else that comes up, I will send to the appropriate person, whether that be the primary care physician or the endocrinologist. And, or if there's no really good reason, going back to our checklist, that checklist item number 1, if I can't find a good reason why this didn't heal, I'm going to send them for further bone mineral workup, just to see if there's anything that we can do. But it's interesting because it's not going to change what I do a lot of times. It's just going to augment what I'm doing. And I'm curious to hear, what you do, Ray, and what you do, Mitch, with this, and what your thoughts are.
To Paul, to answer your question, I think I do something that's very similar to you. If there is something osseous wise on x-ray, if there's a physical exam finding that's unusual, if there are laboratory studies other than vitamin D that are really way out there, and I can't find a good reason otherwise for this patient not to heal, that's when I send patients to endocrinology. Mitch, you there too? What do you think?
Yeah, I agree. I mean, I don't routinely by any means send them, but it really has to be suspicious. Rarely do I send them.
Agree.
Yeah.
All right, Paulie, what'd you do, man?
Yeah. So what did we do? So for this one, we'll go through that checklist real quick. So maybe an extrinsic cause, decreased thyroid hormone, decreased vitamin D. We'll treat that. What about mechanical factor? The initial treatment was an exchange nail. I don't think that it really addressed the stability, and we'll get back to those x-rays when we go to the question. What about biology? Well, there's definitely a biology problem. It's atrophic, oligotrophic in nature. My concern for infection is low, and of course the labs were negative, but it's always possible. But in this case, given the fact that she didn't have pain at rest and so on and so forth, I didn't really think that she was infected. I think this just was someone who just didn't heal because of mechanical reasons. So how did I address this? Well, given the atrophic appearance, again, we're going to add something. How can we increase stability? We're definitely going to do that. And limb alignment, not an issue. For her, getting back to work as soon as possible. She's not going to want and tolerate 9 months in a frame or 7 months in a frame, heaven forbid, on the femur. My God, that would be awful for someone with her body habitus. So we'll go back to the question about what would folks do, and here are those x-rays. So we'll load that polling question up. People asked earlier about nail dynamization in the femur and exchange nailing and bone grafting and all sorts of different things that we could do. We're getting a wide variety of responses. Ray or Mitch, if you have any thoughts on what you do or some of the responses in the audience.
That's a great question, and I'm going to echo the question of one of the panelists earlier that I said I would answer live, is exchange, my go-to a lot, because, I'm not as skilled maybe as you are with these things, is if I've got a nail in and it's looking remotely hypertrophic or even oligotrophic, I'll exchange nailing, I'm really good with exchange nailing. Is there a role for that in this kind of injury?
Yeah, I think there is. I think that the key things to look at with this is that she already had exchange nailing and it failed. So the definition of insanity is trying to do the same thing twice and expecting a different result. So that's sort of, that plays into the thinking there. But if you look at that lateral, especially, look at the canal distally, and that size nail that's in there is a 13 or 14, I believe. Getting it up to the highest size, which is a 15, typically in most manufacturers, that's not going to address that distal segment. That's not going to add that stability. It may add some biology with the reaming and the localized bone graft, but it's not going to add that stability. I think that's key for these. So
we talked about dynamization in tibias. Does dynamization have a role here? Like if she hadn't previously had a exchange nail, if this was index procedure, how about dynamization here? The dynamization question is coming up a couple of times too.
Yeah, I think that in this particular case, it's too metadiaphyseal in my mind for dynamization. I don't think that I think you're going to favor instability over compression, which is what you want from dynamization. Okay. And that's why in my mind that wouldn't be an ideal treatment for this particular case.
Well, show us what you did.
Yeah. So my choice was plating over the nail with autograft. So to go back to that metabolic issues, supplementing the vitamin D and referring for hypothyroid, but not delaying treatment, just getting that going while we were treating her. For the lack of biological activity, plating over a nail, we can get directly at the non-union and disrupt the cortex and increase the inflammation, increase the blood flow locally without reaming and taking out that nail. And then also depositing that bone graft local, which gives you the substrate and the progenitor cells that you're looking for. As far as stability in a metadiaphyseal fracture, adding the plating over the nail increases stability. And Mitch talked about this earlier, and he loves the concept of mixing those two together because that gives you that stability that it's craving. And as we alluded to, exchange nailing is unlikely to improve stability tremendously in a case like this. But what about those patient goals? Well, in my practice, when I do plating over nail, a lot of these I will do percutaneously, and that means the plate will be applied percutaneously as well as the manipulation of the bone grafting site. And I'll allow these people to weight bear these immediately. Some people like Joe Schuh, Carolinas, have what they call he has a outpatient non-union pathway where he's doing these cases as an elective in and out same day procedures. And he has a reported success rate that is greater than 85%. I think it's like 88%, some of those lines. So it can be pretty successful. It's been pretty well described in the literature overseas as well, and sort of an older technique, but can really add a lot to what this lady is craving. So here's her 6 weeks post-op x-ray, and you can see already bridging callus on the lateral cortex, and the medial cortex not as much, but posteriorly you already see bridging bone. Anteriorly not as much, but you see there's some activity going on. But at 3 months laterally she's all healed, posteriorly and anteriorly looking pretty good. Medially still a little bit loosened, and then here's her at 1 year, and she's completely
Paul, I mean this is an amazing case. I'm telling you, I have 2 or 3 patients where the thigh is so big that it's the same non-union line. And I think the nail is so long because I'm so cool as a surgeon that the nail is super long, but the fixation is so far away that I think it's just not stable. And I know you keep talking about Brinker. I think Brinker just published, he revises these with these custom nails that have added interlocks very close to the fracture site. I mean, it makes, just again, back to the first polling question, nail dynamization versus this. I mean, it's like totally opposite ends of the spectrum. This is amazing, Paul. You're amazing.
Great case.
You know what? You're pretty good too, Mitch. We'll high five each other later.
I mean, seriously, look at the callus, Paul, like biologically, look at the callus. All right. I'm not going to talk
Very nice case. And Paulie, thank you for that. And to keep us on time, and I think I get the sense from our audience that we probably want to see all the cases and still have a little time for questions. And so, Mitch, I'm going to ask you to show your last case, and then we can take a couple more questions. I know we might be working on going over time, but I'm going to try to keep
I'm going quick. All right. Not going to rush it, but I'm going to go quick. Okay, it's a tibial non-union. So 62, he presented with deformity and pain. It's been 4 years for this guy already. Multiple surgeries. He had a distal tibia fracture, status post ORIF with screws alone. Won't discuss that. That failed. That was revised to an IM nail. That failed. He revised to another IM nail plus allograft, and that failed as well. So like Paul said, his case, you can't just repeat the same thing. These are the presenting x-rays for him. And again, what do the x-rays demonstrate? Reflect on that. How do you examine the patient for the deformity, clinical exam, and what imaging modalities are necessary? So we got a CT scan to show, what viable and non-viable bone was there. I thought it was characterizing this as hypertrophic. I think it wants to heal. It's deformed. So this is the limb alignment x-ray. And you can see here the patient is in a significant amount of varus, and the varus is coming from the patient's tibia. Patient doesn't really have a limb length discrepancy. So it's basically coronal deformity and torsion was okay. Same checklist that Paul mentioned again, you know, why didn't this heal? How are we going to treat this? And we got to tailor the treatment for this guy. Doing an exchange nailing on this guy is, for me, was going to be low yield. So problem list for me, retained IM nail, retained distal screws. He's got a varus limb coming from a varus tibia. He has no apparent signs of infection. And deformity correction is going to be very important for me to achieve for limb alignment and potentially biomechanics. And I cannot realign this tibia with an exchange nailing. And plating for me on a distal tibia with a monster hypertrophic non-union, I think is totally fine. But again, you're either going to have to redo an osteotomy or mobilize potentially stiff non-union site. My non-union characterization is hypertrophic. And again, I'm going in as a rule out infected non-union, not a infected non-union. Ray, is my pace okay? Am I going too quick? I'm going to keep going. Okay. What is your plan here? Plan. Remove the hardware. We're going to re-ream the IM canal to stimulate the non-union site. Take cultures from the non-union site, opening it. I'm doing a Lizarov concept, which is an adjacent corticotomy to stimulate this hypertrophic non-union, and I'm going to drive limb deformity correction at that non-union site. And I'm going to use a hexapod, but I'm going to use a hexapod that's mega monster stable. So it's a hypertrophic frame for stability. Basically, same thing that Paul did with the IM nail plus plate. So here I am. I pre-drilled the non-union site, like Paul said. This is where I'm going to do the corticotomy. So while I ream, you're going to get local deposits at that non-union, at the corticotomy as well. The frame is on. We're doing a percutaneous corticotomy, and we're adding a ring distally, and we're putting a lot of fixation on this ring. So here's the x-rays in the operating room. You can see the patient's varus deformity, and you can just use virtual software, any software you want, and you can drive your limb deformity correction with your computer software. So I think it's pretty elegant to do that. You can check your alignment while the patient's in the frame to make sure you're happy. You can do little micro adjustments to help yourself make sure he's aligned. So this is him 6 weeks after the frame was removed. He had very good callus forming on both sides. He was pain-free, and he did quite well actually at the end.
That's a great case, Mitch. That's really nice and elegant. A couple of questions that come up. Yeah. So go back. So the first question was, you were not concerned via infection, or you were concerned via infection?
No.
Okay. So what do you think about?
I mean, again, and not to be cute about this, it's either rule out infection or frankly infected. I did not think this was infected. Obviously, I can't be sure, so I'm going in as a rule out infection. But again, I'm using a ring fixator. There's going to be no new implants in there. So if it is infected, it's not necessarily catastrophic.
Speaking of infection, a question that keeps coming up, I'd ask both of you all, if there's
Ray, you're very good at holding you're not laughing. You got a little lady there.
If there's question of infection,
yeah,
intraoperatively, are you using neutrophils per high-powered field routinely and coupling those with your laboratory studies, and what do you make of those?
I'm not that sophisticated with infection. I don't wait for that. It's usually a little bit more macroscopic for me, but I'm trying to use implants that it's not going to sabotage my whole thing. So I'm using typically a hexapod. Now listen, in November we're doing an osteomyelitis webinar. These are not the infected tibia non-unions that I'm presenting. These are aseptic, practically speaking, but I go in with a rule out infection mindset.
Okay.
How long
how about you?
Frame on for?
This got probably about six months also.
and how long? So you follow the same algorithm where you're going to correct the deformity over the course of probably 1 to 2 weeks, and then you're slowly going to compress the bejesus out of that.
Not so much compressed in this case because he's got a corticotomy. So I'm just going to drive the Lizarov method science with that, and then he should just naturally heal this according to Lizarov's principles, this adjacent corticotomy technique.
Guys, we're just a little bit over time. I'm going to ask just a few, like almost rapid fire questions from the audience and try to summarize this, but I want to make sure that all our audience questions are answered. How about, is there any role for pathology to look at a fresh section intraoperatively? Do you do that routinely, or only if you suspect tumor or something really, really strange? Mitch?
Academically, I always send for pathology. It has no practical value for me.
Yeah. Paulie?
I don't bother. It's too all over the place, and it really is sort of a very non-specific thing, because a lot of these have inflammation there as well, especially when you have a pseudoarthrosis.
Mm-hmm. How about, can you describe the percutaneous technique? You talked about percutaneous plating of your femoral non-union, Paul. Could you describe, is this a trans-articular retrograde insertion of the plate and then percutaneous screws, or is there something different you're doing?
Yeah, so for those cases, it's usually 3 incisions, and sort of 1 distally, 1 superiorly, and usually it's retrograde. It depends on the patient's anatomy, but usually retrograde in the femur, and sort of contour the plate over the non-union. Hers was pretty straight, but sometimes it's not, and I will slide that up percutaneously and place a good number of screws through the incision for the percutaneous incision application, but the rest I'll do percutaneous. And then the 3rd incision is anterior laterally, typically, to do the work on the bone.
Very good. So it would be safe to say that the role of that plate in using compression and additional stability, there's a whole lot of role for that application when you had that particular non-union.
Oh yeah, that is the main driving force. In Joe's shoe series, he doesn't even use autograft. He actually just uses cancellous chips, which I haven't jumped on that bandwagon. If I'm there anyway, I feel like it would hurt my soul if they didn't heal after doing that without not doing an autograft. So I'll still use autograft.
This dynamization keeps coming up. It used to be routine at 6 weeks. Can you make a comment, Mitch? Used to be routine.
I honestly have no experience with dynamization at 6 weeks.
Yeah. And then we learned better.
Yep.
So it doesn't seem to have as much of a role as very specific situations where it works out for folks. Yep. Most of the time, it turns out that it doesn't seem to be, the perfect fracture doesn't exist.
We have better options these days, is what I think.
It's a bit, like I'm not poo-pooing it. It's random for me. I don't know when to do it. I definitely would not do it at 6 weeks.
Okay. And then and what about, Paul, if you're in your last case, what about just percutaneous stability screws around the femoral nail, like percutaneously applied blocking screws?
I love that. By the way, Paul's case with the plate and the nail is the best case of the talk.
Well, I mean.
And I would love those lag screws around hypertrophic non-union. I have no experience with that. Paul, go ahead. I jumped on you there.
Yeah, I think that's a great thought. And I think that certainly would accomplish very similar goals. I just think that the ability to reliably do that when you're putting in blocking screws, my experience and having done tons of blocking screws for blocking assisted nailing corrections and things like of that nature, is it's really hard to get it just perfect. So to get that in there with it really just skiving the nail so it increases stability versus being a complete airball, I think can be fraught with a lot of sadness. But the plate adds a little bit more than just stability within the canal. It also adds a little bit of axial stability as well, whereas just putting screws around the nail would not. So I think that it adds something. So I think there's probably a role for it. We don't know yet. There hasn't been a good series on it, but I like that the plate adds that axial stability as well as the rotational and angular stability.
Okay. Everybody, that's every question that's been submitted. I'd like to dismiss our faculty with my thanks. Certainly, I really appreciate your efforts, your talents. in your mind. And so to summarize, we've classified non-unions this evening. We've talked about sterile versus infected non-unions, and talked about oligotrophic, atrophic, and hypertrophic non-unions and their treatments, and understand that taking care of the remainder of the learning objectives for each and every one of your non-unions is, like Mitch said, a little bit of an art. And so I think you have to lean on the science, but you have to understand your patient's individual needs, the original insults, the biological hazards, either locally or systemically, that may hold you up from obtaining union. So certainly there are many techniques that can be employed, and I appreciate your time discussing specific techniques this evening. For the participants or the attendees, I'd ask you to please hold on, as I understand that there is a post-event survey to be taken. And I wish everybody a good night and Godspeed. Thank you very much.